Thank you very much for letting me be here to talk today in your webinar. And what we're going to focus on today is talking about selective dorsal rhizotomy, the use of clinical gait analysis and making sense of the practice variation that exists throughout the United States of the performance of using this common procedure to treat patients with cerebral palsy. We're going to talk, this is a little bit about the outline and disclosures. We're going to talk about the definition of cerebral palsy, the treatment options, talk about how we identified nerve roots in comparison to the different treatment options and results in both ambulatory as well as non-ambulatory children. Again, disclosures, I have no relevant disclosures. Now, cerebral palsy is a group of permanent movement disorders causing activity limitation or attributable to non-progressive disturbances that occur in the fetal or infant brain. These motor disorders of cerebral palsy are often accompanied by disturbances in sensation, cognition, communication, perception, and or behavior, and the presence of a seizure disorder. Oftentimes, especially in the more severely affected children, they can become medically quite complex. It is one of the most common causes of disability in children, with the U.S. prevalence, though I realize I am speaking to an international audience, of almost 3.5 per thousand lives birth. It is higher in males and non-Hispanic Black children. The interesting thing is why investigating permanent treatments for spasticity is that the lifetime cost for these particular patients can approach up to $1 million in medical care, use of medications, and other things. So, which is why the use of selective dorsal rhizotomy is particularly attractive. Now, cerebral palsy it can be classified in a variety of different ways. It's first classified by type of movement disorder: spastic, dyskinetic, athetoid, or mixed. And this is important because as you get more severely affected kids, you can get dystonia and other things that go along with spasticity, and you have to be able to recognize that prior to the administration of your treatment modalities. You then need to talk about the topography of impaired motor function. Are they monoplegic, diplegic, hemiplegic, triplegic, or quadriplegic? And then the severity of the motor dysfunction is also important because your treatment options will vary depending on this. And oftentimes, which I'll show you, is it's used as the GMFCS levels 1 through 5, which is important to be able to talk about the language in evaluating each of these treatment options, because the GMFCS treatment for a 5 kid may not be the same as a GMFCS treatment for a child that is only mildly impaired. Now, the definition of spasticity is as follows. It is a movement, or is it a motor disorder characterized by velocity-dependent increase in the tonic stretch reflex? There is exaggerated tendon jerks resulting from hyperexcitability of the stretch reflex. It is one component of an upper motor neuron symptoms. And this is a schematic showing the increased excitability of the stretch reflex is accompanied by decreased supratentorial inhibition, leading to the spasticity that we all see when we treat these children. The recommendations for classification of cerebral palsy include the motor abnormalities, the associated impairments, the anatomic, as we covered, and radiologic findings, and then the causation and timings. This is a little schematic showing the GMFCS levels 1. Children are able to walk without limitations. Level 2, walk with limitations using AFOs or other devices. Level 3, the children are walking with handheld mobility, and so on and so forth. Up to level 5, which these children are often transplanted in a manual wheelchair and require significant assistance, and are often associated with other medical concerns. Now, it's important to evaluate this because a lot of people think of CP as a non-progressive condition. However, it's not, especially in the more severely affected kids, levels 3, 4, and 5. As you get to be a teenager, there's plenty of data showing the natural history of these folks showing a decrease in motor function as you get older. We unfortunately get larger. It requires more inertia to get our body masses around, leading to decreased neurological function or function in these children. This decline is especially important because your treatment that you diagnose or impart on these children needs to account for this decrease in motor function. Spasticity, though, I should say before we start talking about treatments, is also important because spasticity removal alone does not directly lead to functional gains. It may contribute to contractures, impaired gait mechanics, and muscle imbalance, but it may be attributable to some function because it may pad bony prominences, it may prevent DVTs, and it may be useful in bracing of these children. The goals of treatment for spasticity are important because what you have to do or remember as you go through these children is you need to remember that improving the motor activities is what this is all about. You need to be able to decrease the development of orthopedic deformities, which get larger, especially as the children are growing in the teenage years. And taking this all into account is how you differentiate the different types of treatments that you end up prescribing for these children. This is a child that's turn it down for a sec. There we go. And it's important to see how these children are walking when they get to be 4 and 5 years old. And as you can see, he's starting to develop, he's toe walking. His joints occupy both ankle as well as knee occupy. He's unable to jump, leading to some significant functional impairments compared to the children that are normal children that are his age. So the question is, what do we do? Now, the nice thing about, and the reason why selective dorsal rhizotomy is important is almost 2/3 of the children are GMFCS 1 to 3. And this is important because these are the ambulatory children who are all seeking to treat or make the correct decisions for. About 30 to 40% of the CP children are the wheelchair-bound children, and this last group may have significant other comorbidities, making it important to really talk about what kind of treatments you're prescribing, because some of your treatments may have consequences in development of seizures or some other unforeseen consequences if you don't evaluate them carefully. Recent article by Novak et al. Really puts it into a red light, green light kind of traffic pattern in determining what's best. And there are a lot of treatment options, as this schematic shows. And what I would like to point out is that for tone, selective dorsal rhizotomy is one of the green lights for treatment, along with other kinds of treatments like Botox, and for which there's good treatments. Development of contracture or correction of alignment, it is a yellow light, or to be used with caution, that it doesn't really contribute to it, and it's also doesn't really contribute to the development of motor control, because as you can see from this, because it's really focused on the management of tone, which is the primary underlying problem for a lot of these children, especially ambulatory children with cerebral palsy. Other kinds of treatment options in a little bit more of a area that you can read, showing injectable medications, Botox injections, and other kinds of drugs, use of oral medications, baclofen, diazepam, dantrolene, and intrathecal medicines that a large portion of other folks use, called using baclofen. And there is the surgical intervention really for treatment of spasticity, which is selective dorsal rhizotomy. Now, with that, let's talk a little bit about what is a rhizotomy. Is by and large a permanent procedure. It is the selective cutting of nerve roots. This really began in the 1800s, describing reduction of hypertonus following division of afferent nerve roots in the de cerebral cat. This is it then was first described in the early 1900s by Forrester and Cushing, where they noticed that people that had diseases of the sensory nerves didn't have any spasticity, so they ended up cutting the nerve roots. The division of did relieve spasticity. However, it was complications of significant muscle weakness, loss of sensation, as well as meningitis, did not really, basically minimize the level of excitement related to this procedure. When it sort of took off in the 50s and 60s, when a guy by the name of Peacock out of San Francisco really began to develop it and said, well, we sort of know what happens when you cut them all. What happens if we just cut a portion, and let's add EMG to it? The recognition of large control studies was important because they were really minimal at that point. So he developed his first 60 patients. It really showed that the selective dorsal rhizotomy was important and really did permanently reduce spasticity, leading to long-term functional gains. This is really his criteria that he ended up using. He really looked at no Botox injections for at least 6 months, because any monitoring that occurs with Botox injections is going to be problematic if you do it any sooner. 6 months is usually the amount of time required for Botox to wash out. You need to be at least 1 year after orthopedic procedures, and you need to be able to undergo the physical therapy after the procedure, because you do experience a functional decline afterwards. There has to be good control, trunk control, and no significant scoliosis, because if there is scoliosis, you're going to have one side is going to be exceedingly easy, and the other side is going to be rotated under the spinal cord, being exceedingly difficult to end up performing the rhizotomy. A lot of these children we use have PVL associated with them. However, we are starting to do some with congenital malformations and showing very good results. The preoperative evaluation for selective dorsal rhizotomy is hip subluxation or dislocation. We look for in the lumbosacral spine for hyperlordosis and scoliosis. We look at the MR for the brain and spine for term delivery, as well as spine, especially if that's important in the younger kids. Just recently diagnosed somebody with a unrecognized cervical spine injury and congenital absence of the pedicles of C2 with a spinal cord injury that had been diagnosed with cerebral palsy for their entire life. Gait analysis to verify this for spastic diplegia and really to serve as the goalpost to evaluate postoperative progress. We are very careful, while it's not a absolute contraindicator, fixed orthopedic deformities do affect prognosis, and families need to be made aware of this and the fact that the rhizotomy will not fix the orthopedic deformities, and a certain percentage of the children that are undergoing a rhizotomy may need orthopedic surgery in the future. This is really the SDR demographics at NCH, and as you can see here, a large portion of what we are seeing and doing are the diplegic children. About 55% of what we do are either are diplegics, and other 15% are hemiplegics. With over a quarter of the patients are quadriplegic, meaning these are what we call palliative rhizotomies, which I'll talk a little bit about later in the talk. And there's the SDR by GMFCS level. Some of the best results we're seeing are the GMFCS1 children. They're seeing the biggest change in their functional, their biggest functional gains in ambulation, and returning a large portion of almost normal ambulation. The mean age, as you might expect, are about age 8, and anywhere from ages 4 to age 12 is really the prime area where most people are undergoing a rhizotomy. Though I am one of the first centers that are doing adults as well, because with the properly selected adult, you can achieve some very good functional results. This is really a very busy schematic showing the presence of how we arrive at the decision for surgeries. Is the SDR considered? Is spasticity causing pain or impacting function or mobility? Are there any significant ataxia or dystonia present? And does the child ambulate? No. What are the family goals? Is it to improve the care? We consider what we call a palliative SDR. If they do ambulate, do they have selective motor control? Is tone primarily being used to participate in ambulatory activities, or are they able to participate in intensive post-surgical therapies? Because there is a functional decrease for upwards of 3 to 6 months after the procedure that families need to be made aware of in determining your functional outcome following SDR. Now, what is an SDR? It's a partial deafferentation of nerve roots, 60 to 75% from L1 to S2. We use EMG testing of these nerve roots, and in contrast to PCOG, I was trained by Dr. T.S. Park, and we do a single level L1 laminectomy with ultrasound localization of the conus. These rootlets are sectioned that have responses beyond their myotomes, which I'll talk a little bit about later. We do this by positioning them prone on the table, doing an incision, as you can see there, at approximately the lower part of the conus. We do our laminectomy, and then we begin stimulating them. What the conus looks like, for those of you that wanted, this is the ultrasound picture that we're looking for as we look in the interlaminar space to choose our appropriate levels. What we want to see is not the whole spinal cord, because it makes it quite difficult, but If those can see my pointer, the end of the spinal cord is here with nerve roots on top and below. And this allows us to be able to divide out the dorsal, looking at the side of the spinal cord, being able to divide out the dorsal from the ventral nerve roots. And what does this look like in the intraoperative section? And here's a video. And this is why EMG is important, because, as you can appreciate there, all of the nerve roots look the same, and you can't tell motor versus sensory nerves. There is some functional components that when you stimulate the motor nerve or mechanically stimulate them, you do get a elected response. And what I've done there is divided out all the dorsal nerve roots, and what I'm staring at there is the side of the spinal cord. So you have both anatomy as well as electrophysiology to divide out the sensory nerves. Then we use our EMG, our probes, to be able to test the nerve. And we have thresholds that are less than 1, and those are highly suggestive of a motor nerve. We also mechanically stimulated them. So when you're dissecting out these, we divide them out into 3s and cut 3 of the nerve roots. It's important because you need to, what we've shown in St. Louis is that this 60 to 75% threshold ensures that you do not have or have minimal return to spasticity at 6 months. Once you get down below 50%, and I'll talk a little bit about the meta-analysis later on in the talk, you start to get return to spasticity at approximately 6 months, and not as good a functional outcome as you would if you get up on the 60 to 75% range. Now, there's some significant variability that exists in SDR in the number of laminectomies and the number of nerve roots that you end up cutting. This is the list of the articles, thinking about as Peacock there up top and Park, as well as some of the other current techniques that are being employed throughout the United States. And a schematic of this showing there's everything from the 5 to 6 level laminectomy that Peacock down to the 1 level in conus rhizotomy that is done by Park and performed by most of the people that are trained by him throughout the United States. There's other infraconus rhizotomies that is done out of Seattle. Are pretty much the same. And I'll discuss some of the technical differences in number of nerve roots cut, because that's important in understanding and making sure that you have the best outcomes possible. Now, the reason I do the single level laminectomy and multi-level, this is a debated difference, but the length of hospital stay is less for a single level laminectomy. I can ambulate them at day 1 with appropriate pain control. PT usually commences on day 2 to 4 with a single level procedure, and no one is staying beyond 5 days. There are similar gains in function, and daily physical therapy is often much easier to be initiated from the single level versus dual level laminectomy. And the other that's published in a few of the papers is that you have completely eliminated the need for deformity surgery when you use 1 level versus a multi-level laminectomy. In the several hundred that I've done at Nationwide and the over 5,000 that TS did, we haven't seen any deformities related to the performance of the rhizotomy. It's important, you need to have a very good understanding of the localization of the nerve roots if you're going to do a single level laminectomy. It does not allow for complete visualization. It's basically revolves around a pattern of muscle involvement. Muscles in the single level laminectomy are grouped according to specificity. Responses from vastus lateralis and tibialis anterior suggest a preferential L2 to 4 involvement. Then you have the lumbosacral involvement, and then you have the pure sacral involvement and foot responses. Usually, you're not able to localize a specific level due to multiple overlapping myotomes. There's regional, as I've said, with lumbar, lumbosacral, and sacral as you go through the single level or infraconus rhizotomy. It's anatomical isolation and separation. Oftentimes, mechanical tapping can differentiate dorsal versus ventral nerve roots, and electrophysiologically, lower thresholds and larger evoked responses really tell you that you have a motor nerve root and that you're not going to section in the ambulatory children. Grading is usually performed at each rootlet to determine the stimulation threshold The normal response is a stimulus-locked, level-specific unilateral evoked response. Differential schema are used to grade the abnormalities based on morphology, persistence, and spread. What I end up using the Phillips and Park grading scheme, grading it from 0 to 4+, with 4+ being sustained responses to the contralateral leg. We're looking to identify the 3+ and 4+ responding nerve roots, but we also are also seeking to get to the 60 to 75% threshold in sectioning of the nerve roots, because I do think that is critically important in determining that you achieve a good and permanent reduction in spasticity. They showed a higher significant grade difference between individual segment levels, with higher grades at lower nerve root levels. And similar reports by our group to this are showing that your thresholds do go down as you go up into the sacral nerve roots. The other important thing for rhizotomy is pain control. And I'd like to make specific mention to this, because this is continued in that when I first started at Nationwide, we did use PCAs because we didn't have a lot of experience with epidural catheters. We had to place these guys in the PICU watching for respiratory desaturations for at least the first 6 to 8 hours. We instituted epidural catheters. We've been doing this ever since, and we've completely eliminated the need for narcotics. They're now a floor patient and can ambulate on postoperative day number 1. All of the, as this paper that we published in 2020 showed, all of the complications for use of narcotics are almost completely removed by the use of the epidural catheter and Neurontin, which we place on postoperative day number 1. So this is important because it has really made the management of these children much, much easier in getting them to the physical therapy that they need. The complications that we see are oftentimes sensory disturbances lasting 2 to 4 weeks. We talk about paraplegia and incontinence. We're not seeing it, haven't seen it ever. And then CSF leak, we can get a little bit of accumulation of fluid underneath. An infection with the use of vancomycin powder, we haven't had an infection in over 5 years. In the literature suggests hip subluxation increasing lordosis, though insufficient data to determine whether this is part of CP or part of the single level SDR. Now, for the sake of time, we're going to talk next about post-SDR therapy, because there's significant variability that exists, and this is a critical component of the decision to undertake an SDR. Goals established before the procedure are an important part of the postoperative therapy, and the absence of tone allows for strengthening of the individual muscle groups. It begins as soon as 2 days after the procedure and is out of the room, especially when the patient is out of bed on day 2. If the patient is walking prior to surgery, the goal is to have them walking by discharge. Not always achievable because of pain and behavior, especially in the really young children. We want them weight-bearing, gait training, strengthening, gross motor skills. Orthosis are assessed if new braces are needed. We do construct them. Braces are typically issued prior to discharge. And we have an extensive program in outpatient therapy where we help the patients that we end up undergoing a rhizotomy in a program for PT and OT, depending on whether they are a GM ambulatory child or a wheelchair-bound kid. Goal is to continue to progress patients to their highest level of function. This is poorly defined as patients are widely variable in their presentation pre-surgically. The expectation is that ambulatory patients will return to baseline within 6 to 12 months. Protocols call for physical therapy for 24 to 36 months following surgery, tapered as indicated. Weakness for these patients tends to persist in the glutes, tibialis anterior, and gastroc, or the posterior chain. The couple and timing of interventions with dosing of intervention optimizes plasticity and participation in pediatric neurological conditions, specifically cerebral palsy. For SDR, we are coupling the timing of an intervention with the dose. And SDR permanently alters the neuromuscular system, so a high dose of PT is warranted for optimal motor outcomes. Physical therapy is generally recommended for at least 6-month duration, typically 12 months post PT, and we usually recommend up to 140 hours during the course of recovery. There's to emphasize this, there's no agreement on optimal frequency, intensity, timing, or type. This is one of our main research interests as well here at Nationwide, and this is from a recent publication. showing that what we do in all these, and wheelchair management, evaluations, tests, gait training is a big component. Modalities and casting, we actually look is in about 11%, and neuromuscular reeducation in almost a quarter. What there is the dotted line is the median of completed PT and the median of recommended PT. And you can see in a very small sample size of about 12, there was a big difference what we were recommending versus what children were getting, either because of parents, because of insurance, and some other things. So we're still working to really define what the most optimal dose of PT is following SDR, because we need to make sure that these children are getting the appropriate amount of therapy, the appropriate amount of strengthening to ensure this lifelong disease continues to be held at bay. What do they look like? We'll go through a few cases here. This is age of walking at 15 months. This is a GMFCS level 1 child. Or orthotics, whereas a left SMO, right hinged AFO with dorsiflexion assist. Goals, mom would like to have less pain and less falling during procedure. This is what they look like pre-SDR. Obviously, one side's worse than the other. 12 months post-SDR, was able to change the orthotics that they were using. They were able to have an increased heel strike and improved overall gait. They've not required any Botox, which they were before, and they're not requiring any supplement medications. All of the different palsy measurements were all showed an increase in global function, happiness, comfort, and pain, as a variety of other therapies indicated. What do they look like from a on video? This is, again, the gait analysis as we did, and you can see it'd be hard pressed to say this child actually has spasticity based on the gait they end up. So this has worked, and she's continued to get stronger as she's gone on, and she's now probably 3 years following her SDR. This is really the gait analysis showing an increased heel strike in both left and right following SDR. And we have a number of other examples like this. Since not everybody is a GMFCS1, let's look at a few more. GMFCS2 children, a little bit more severely affected, usually currently on a 2-week break with 2 intensive physical therapies, ambulatory status. GMFCS 2 to 3, trips, non-falls, non-pain, non-reported, wearing hinged AFOs. And what do they want? They'd like to not need a walker and to walk longer distances. This is what they look like. And I need to say, use the posterior walker always. Slides down the belly, goes up with handrails or on hands and knees. Post-surgery, 1 year. Variable day-to-day, uses posterior walker for now long distances. Is able to use stairs with a handrail or handheld assist. So a significant functional change in this more severely affected child, leading to the fact that, basically, and this has continued to persist, and he's continued to make progress as he gets further and further out from his rhizotomy as he continues with intensive physical therapy. Again, showing an increased heel strike, again, in the post-surgical patient. And it's important. And so what do we get when they get older too? Most people says once they get past 12, you can't do a rhizotomy. And I would disagree with that, in that you pick the motivated young adult here, trips, falls occasionally, post-surgery, getting closer and closer to a normal gait. This guy actually ran a 5K, which he couldn't do preoperatively. So it's been exquisitely important to really establish the goals of the patients beforehand, because with the properly chosen patient, you can really achieve a very good functional response. More severely affected kids, gait pain, yes, trips and falls frequently, and basically went from somebody that's clearly affected. This is sort of the range of ambulatory children that I'm seeing. Basically, he's walking on his toes. What does he look like 1 year post-op? He's now, he probably will need some lengthening afterwards, but is now able to get around without the walker, and has really done basically gait pain is almost completely gone. It's one of the symptoms that we do the best with, and really some nice functional improvements following an SDR. And there's his 18 months post SDR, and you can see upper extremity and physical functioning less, transfers basic mobility significantly higher, comfort pain significantly higher, and global function. So he's really done well. This is sort of a schematic showing that we're seeing in both upper as well as lower extremities, we're seeing decrease in Ashworth scores, and in both upper as well as lower extremity function. And we're doing this both in children with dystonia as well as not. We just have to caution that when we see dystonia, we need to warn the parents that sometimes can affect prognosis. We also are doing these in non-PVL children, in that some have ventriculomegaly or periventricular gliosis, as well as some congenital malformations as well. So a lot of the patients with the properly chosen can really do quite well following an SDR. How do we use gait analysis? Gait analysis does not alter surgical decision-making all the time. One study in 11 patients across 4 centers demonstrate treatment recommendations varied for 9 of 11 patients. So little published data on surgery based primarily on gait analysis. Now that's a bit of heresy because there's a number of centers that use this solely for determination of SDR, but I think this has never been shown to be superior to the qualified clinician in determining who would benefit from an SDR. We use gait analysis in clinical decision-making to evaluate change, to identify additional interventions, maybe orthopedic surgery, bracing, and other therapies in their post-surgical change. Selective dorsal rhizotomy meta-analysis. This is one of the only studies that have had 3 randomized controlled trials. What it showed is that Ashworth scales improved when compared to PT alone, as well as functional changes, largest clinical important difference in ambulatory children. What people don't realize is one of the randomized controlled trials didn't work. And that's the one that only cut 20% of the nerve roots, because in that situation, what you ended up seeing return to spasticity at 6 months. So you did not see it, but when you sum all of them together, SDR plus PT in a randomized controlled fashion is superior to PT alone. Another English study, a prospective observational cohort study showing quality of life 2 years following SDR in ambulatory children. SDR improved both function as well as quality of life for all of the ambulatory children that were studied in this particular observational cohort study. SDR, the reason I'm a big fan of it, is also permanent. It shows, this is long-term benefits showing up to 15 years that you get a reduction in Ashworth, as well as an improvement in GMFM as well. And this is improvement has been shown to persist for upwards of 20 years following an SDR, as I'll show in some of the more recent, in some of the stuff from both St. Louis as well as from Michigan. Participants showed large improvements in gait pathology. They did require some more interventions, but it is important to note that this lasts upwards of 20 years. This is one of the first patients I did. This is a 30-year-old that was a fitness instructor. This is post-op, and if I told you she worked out every single day, you wouldn't know she had cerebral palsy or was it GMFCS2 prior to performance of the procedure. It doesn't eliminate the need for orthopedic procedures, but it does reduce the need for orthopedic procedures, and it reduces the need for Botox injections. The improvement here is durable in long-term, in lower limb tone and gross motor tone and performance of ADLs. Functional outcome in adults and adolescents with cerebral palsy, depending on, it does positively affect your quality of life. And this is the functional outcomes of 20 to 28 years with TS, which has probably the biggest collection of long-term follow-up in these particular, showing they're at a higher level of ambulation, 91% improvement in quality of life. And though a significant portion of them did report orthopedic procedures. Case control study out of Michigan showing SDR did not significantly predict pain interference or intensity, though it did relate to a lower decline in gross motor function as these children got older. So most people generally in the ambulatory children think that it's quite well within your purview to do SDR on ambulatory children. But what I also like to introduce, for those of you that you can also do this in the wheelchair-bound children as well, the GMFCS 4s and 5s. There's a couple of studies out there showing that SDR is a treatment option for the non-ambulatory patients. It may reduce pain. It may reduce the need for orthopedic procedures, though it may also increase the need for treatment for dystonia, because once the spasticity is removed, the dystonia becomes more apparent. Further study is needed for the role of this, and it's one of the things that we're currently submitting NIH grants for, because this is one of the things that up to 30% of the wheelchair-bound children can have a mixed movement disorder. This is one of the best studies in comparison for an intrathecal baclofen pump. 71 consecutive patients who underwent SDR were matched with 71 patients who underwent ITB therapy. These are all non-ambulatory GMFCS 3 or higher. SDR provide a large improvement in tone, passive range of motion, and gross motor function when compared to ITB alone. Fewer patients required orthopedic procedures, but both had a high degree of satisfaction. So while I'm not going to tell you that it's a better option, it is an option to consider for the wheelchair-bound children. SDR, to sort of sum up the recommendations, it reduces spasticity for up to 15 years following SDR. Gait kinetics and speed improve after surgery, at least in the short term, and may remain long term. They're like GMFCS with motor involvement. The non-ambulatory children are likely to continue to require additional spasticity management, and small improvements persist in gross motor function in ambulatory children with SDR plus physical therapy compared to PT alone. It has a positive impact on body structure and activities and participation. It is unclear in the long term. The majority of patients who receive SDR would recommend it to others. This is important because remember, this child, this is the first one. As you can see, this is him in rehab during his 2 weeks of inpatient rehab, and you can see his gait has changed significantly. And he's down in Texas, and he's continued to improve. And he remains to be without spasticity in his lower extremities. It's an excellent option for spasticity. Where we're missing as far as data goes is that we do not have a lot of direct comparisons between each of the treatment modalities. But what we do have is that it shows that SDR results are durable and complications are rare, although future studies are necessary to directly compare the Botox, SDR, and other types of therapy management for treatment of children with cerebral palsy. With that, I wanted to thank you very much for your time, and I'll take any questions at this time.
Thank you very much, Professor. You've shown great case examples. So far, there is no question or contribution in the chat box. I would like to invite maybe some of our audience to share their thoughts with us.
Professor Leonard, can you stop your screen sharing so we can see each other?
Yep.
Okay. Thank you.
Maybe Dr. Efejan would like to say something.
If he's here. Efejan? And there is Edwin from Bulgaria. I wonder if he made such cases and what is he doing? Edwin, are you here? Okay, he's not available. So there's a comment. Thanks. And
yes. Let me read it. Um, it says, thank you very much for the presentation, Professor. Is it possible to try ITB therapy in case of failure in SDR?
Yes, absolutely. And I've done that. They've done that multiple times, especially if the functional improvements in an SDR have not been satisfactory for the patients, especially when you have both upper extremity as well as lower extremity problems. And what we do is we get an sort of when you reduce the tone in the lower extremities, sometimes the families want increased functional gain in the upper extremities. And what I do in those situations is we'll take the catheter and thread it up to C7T1 and to get that upper extremity benefit. So, and we can also go the other way too, in that if families have trouble with baclofen pumps, complication-wise, don't tolerate the medicines, we can remove the baclofen pump and perform an SDR. So you can go both ways in this procedure. But to emphasize, because of the ability to differentiate the dorsal versus ventral nerve roots, SDR is a procedure that can only be performed once.
Thank you for your response. There's another question. It says, how many roots, in brackets, dorsal roots, do you cut, bracket close? Is there any way to decide? So how many roots?
Yes, what we know is that there's some difference. So first of all, I'd like to emphasize it is an estimation, number one. Number two, you have to get above the 50% range, because if you drop below 50% range, you start to get into, that's the reason one of the clinical trials failed, and that the one that cut the less at 20% did not show any difference between PT versus PT plus SDR. What I'm taking with this is the experience. I mean, in St. Louis, TS, we did over 5,000 of these. And that result was taken from this. And there's been a number of other studies that have shown your functional improvements are directly proportional to the number of nerve roots cut. And when you get above 80 to 90%, you start to get proprioceptive loss and some other degeneration of the posterior columns that in the non-ambulatory children you can tolerate, but in the ambulatory children you can't.
Emmanuel, you mute yourself.
Sorry for that. Thank you, Professor Leonard, for your response. There is another contribution from Dr. Cemil Yıldız. Thank you very much for sharing your experience with us. He said.
Okay, Emmanuel, I think there is no any other questions and comments right now, right?
That's true.
Okay. So, oh, there is one more thanks. Thank you. Good talk. Okay. And I want to thank to Professor Leonard, and I want to thank everyone who joined us today, this evening here. Thank you so much, Professor.
Thank you very much for having me. Bye-bye.
Bye-bye.